Welcome to the deep dive. Today, we are opening up one of the most high stakes, high pressure knowledge zones for any future nurse emergency care for the acutely ill child.
Absolutely.
Yeah.
This material, it's drawn straight from Essentials of Pediatric Nursing, and
Yeah.
honestly, it isn't just theory.
No, it really isn't. It's the difference between life and, well, severe disability in a crisis.
Yeah.
Our mission today is pretty simple. Map out those rapid fire priorities, the physiological secrets you need to know. Because in a pediatric emergency, you're often fighting a clock measured in like minutes.
We have to start by acknowledging, the terrifying paradigm shift in pediatric resuscitation.
Yeah.
You're trained to think cardiac arrest in adults, but for children, the landscape is completely flipped.
Flipped how?
Well, their developmental stage, it makes them uniquely vulnerable to external dangers. Things like trauma, poisoning, submersion injuries.
Right.
And their smaller, more delicate systems mean that most pediatric cardiopulmonary arrests, they actually result from progressive respiratory failure or shock. It's not usually a primary cardiac event like in adults.
That is such a crucial takeaway right from the start. If you treat the child like a mini adult having a heart attack, you're probably going to fail them.
You are, because the problem is almost always breathing or circulation failing first.
Okay.
Exactly. And that distinction, it changes the entire philosophy of care. The American Heart Association even codifies this in the chains of survival.
Ah, the chains. How do they differ?
Well, the adult chain emphasizes early EMS, CPR, defibrillation. The pediatric chain, it places its absolute first link on prevention of cardiac arrest and injuries.
Prevention first.
That focus on proactive safety, that's really the foundational principle of Pediatric Advanced Life Support, PAP.
Prevention is the gold standard, of course. But when the child is crashing, we immediately have to implement that nursing process structure, right? Distilled into the AHA Basic Life Support Guidelines, CAB.
Circulation, airway,
Yeah.
breathing.
Yes.
And let's talk about the speed needed here.
Speed is everything, isn't it?
It really is. You cannot afford a leisurely health history. It has to happen concurrently with immediate life-saving interventions. You're doing a rapid cardiopulmonary assessment in seconds.
Okay, so where do we start? Airway.
We start with the airway. Patency is non-negotiable. For most kids, we use the standard head tilt chin lift maneuver. That aligns the airways.
But there's a critical exception.
There is. You must remember this. If there's any possibility of cervical spine trauma, maybe a fall, a diving accident, you use the jaw thrust technique only.
Stabilize the neck, open the airway. Got it.
Exactly. And once it's open, the child gets 100% oxygen and pulse oximetry immediately.
Okay, airway secure. Moving to B, breathing. We use that classic technique. Look,
Right.
listen and feel for spontaneous respirations.
Yes, but the key here isn't just if they are breathing, but how well.
The quality of breathing.
You have to evaluate the quality. Is the effort effective? Or is it shallow, maybe gasping, irregular? If the child has poor respiratory effort, you try repositioning first. Sometimes that's enough.
And if not,
If that fails, you transition immediately to assisted ventilation using the BVM, the bag valve mask device.
right. Okay, so airway and breathing are compromised. The clock is definitely ticking on C circulation. Pulse check location matters here too, doesn't it?
It does. We use the brachial pulse in infants, that little pulse on the inside of the upper arm, and the carotid or femoral pulses in older children.
And you mentioned a critical warning earlier, something about the monitor.
Yes, this is a knowledge nugget that genuinely saves lives. Never rely only on the cardiac monitor to check for a pulse. You must physically palpate the pulse,
Why is that so critical?
because it's something called pulseless electrical activity, or PEA. The monitor might show an electrical rhythm that the wires are still firing, but the heart muscle isn't mechanically squeezing.
So no actual blood flow.
Zero perfusion. The screen looks okay, but the child is effectively pulseless. You have to feel for it.
That's a powerful point. No pulse, no perfusion. So if we confirm circulation is compromised, what's the absolute first move?
Fluid resuscitation is the absolute priority. Usually we use an isotonic fluid like normal saline or lactated ringers.
Okay, and how much? How fast?
Yes, and this is where speed really, really matters. The standard initial intervention is a 20 milliliter jam IV bolus, and it needs to be delivered as rapidly as possible, like you're using pressure infusers or literally pushing it with a large syringe.
Wait, 20 molecular jam for a small child, that sounds like a massive fluid load to push so quickly. Is that safe? Why risk fluid overload?
That's a great question.
Ah,
Because in shock, which is often hypovolemic in kids, the immediate need to restore volume of perfusion, it just trumps the short-term risk of fluid overload.
oh,
We need to fill the tank fast so the heart actually has something to pump. We only reduce that dose to 10 millivolt/time if the infant is less than 1 month old. Otherwise, we push aggressive volume.
Aggressive volume, okay. And what if you can't get peripheral IV access? You know, those tiny veins.
Right. If you can't get peripheral IV access, the rule of thumb is after 3 attempts, or about 90 seconds, whichever comes first, you must transition to the next gold standard.
Which is?
Intraosseous access, IO, straight into the bone marrow.
IO access. Sounds painful.
It often is, unfortunately, but it's life-saving. Any fluid or medication that can go through an IV line can go right through the IO route. It gives us immediate vascular access when peripheral veins fail.
Got it. Okay, so we've addressed the immediate life threats, CAB. Now we move to the secondary survey, starting with D for disability, the neurocheck. We need something quick here too, right?
Absolutely. Time is still critical. We use the AVPU mnemonic. It's quick and functional.
AVPU.
Alert, responsive to voice, responds only to pain, or completely unresponsive. It's a rapid scan of the child's level of consciousness.
Simple, effective. And specifically for infants, we have that built-in physiological window on their head.
The anterior fontanelle. Yes, you absolutely must palpate it, a sunken fontanelle. Classic sign of volume depletion, dehydration.
And the opposite.
Conversely, a full or tense, maybe even bulging fontanelle is a critical warning sign. It shouts increased intracranial pressure, which needs immediate intervention.
Okay. Now, let's pause for a second on something easily overlooked in the chaos. Pain.
Yes, so important.
In the middle of a code, it's hard to remember that we're actively causing pain with IV attempts, IO insertions, all these procedures.
But that's precisely when we have to step back just for a moment and manage it aggressively. Remember atraumatic care.
Even if the child is sedated or paralyzed.
Especially then. They might still be experiencing severe pain. We have to assess using age-appropriate scales and treat it.
Good reminder. Alongside stabilization, diagnostics are usually running in the background.
They are, but, and this is key, these tests never delay cardiopulmonary stabilization. Never. Standard labs usually include ABGs, arterial blood gases, electrolytes, glucose, a CBC.
And if you suspect something ingested.
A toxicology panel, definitely, especially if a previously healthy child suddenly deteriorates for no clear reason.
We also use imaging, right? What's useful acutely.
A chest x-ray is fast, essential. Confirms ET2 placement, maybe finds a foreign body or pneumonia. A CT scan gives rapid tissue evaluation, say for trauma, but it comes with high radiation.
And MRI.
MRI gives amazing details, especially for spinal cord stuff, but in the acute setting, it's often impractical. The child has to be stable enough to lie still for a long time, which often isn't the case.
Okay, let's nail down some critical numbers and techniques now. CPR guidelines. High-quality compressions are key.
Yes, depth and allowing full chest recoil between compressions. Minimize interruptions.
And the ratios are different for kids depending on how many rescuers are there.
They are distinct. If you are alone doing one-person CPR on an infant or child, the ratio is 30 compressions to 2 breaths. Pretty standard.
But if you have help.
In the team environment, 2-person CPR, which is the gold standard, we shift to 15 compressions to 2 breaths.
Why the change to 15.2?
It maximizes ventilation for the child, which is often crucial given respiratory issues are common causes, and it also helps minimize rescuer fatigue. Better quality CPR for longer.
Makes sense. And the actual hand technique for infants also changes.
It does. For one person, it's the 2-finger technique on the sternum. But with a second person, you use the 2 thumbs encircling the chest technique, while the second person supports the back. It gives better compression depth.
Okay, shifting gears to electricity. Defibrillation versus cardioversion. They sound similar, but aren't.
Not at all. Defibrillation is for the chaotic, pulseless rhythms like ventricular fibrillation or pulseless VTach. It's delivered non-synchronized. Basically, it shocks immediately whenever you hit the button. The initial dose is typically 2 joules per kilogram.
Okay, non-synchronized. 2J a kilogram for pulseless chaotic rhythms. What about cardioversion?
Synchronized cardioversion is used when the heart is still generating a rhythm, still potentially moving some blood, but it's dangerously fast. The SVT or VTach with a pulse.
So there's a pulse present.
Right. And because there's an organized rhythm, we have to sync the shock precisely to the R wave of the ECG. If you shock on the T wave, you could induce VFib.
Ah, the R on T phenomenon. Dangerous.
Very. So synchronized delivery is key, and it requires a lower energy dose, usually starting at 0.5 to 1 joule per kilogram.
Lower dose, synchronized. Got it. Now, medications. What if you've got an arrested child and you just cannot get IV or IO access? Is there another route?
There is a fallback, though it's less ideal for absorption. We use the mnemonic for drugs that can potentially be given via the endotracheal tube, lean,
Lean.
lidocaine, epinephrine, atropine, and naloxone. You typically use higher doses than IVIO and follow with saline flush and ventilation.
Okay, lean for ET route as a last resort. Determining the correct equipment size. That always feels stressful. Tubes, masks.
It can be, especially in an emergency. In ambulatory care or ERs, the Broselow tape, that color-coded length-based tape, is invaluable. You measure the child, find the color zone, and it gives you estimated weight, drug doses, and equipment sizes.
Super helpful. But what if you don't have one or you're in a different setting? Is there a formula for ET tubes?
There is, and every nurse should know this one for kids older than 2 years. To estimate the uncuffed ET tube size, you take the child's age in years, divide it by 4, and then add 4. That gives you the internal diameter in millimeters.
Age divided by 4 plus 4. Okay, that's a good one to memorize.
Absolutely. For cuffed tubes, it's often age 4 plus 3.5. But the uncuffed formula is the classic one to know.
All right, advanced airway management, intubation. What's the nurse's role?
The nurse's role as the assistant is indispensable. We're prepping equipment, drawing up meds, monitoring the patient. We prepare for rapid sequence intubation, or RSI.
RSI involves specific drugs, right?
Yes, typically both a sedative or anesthetic like midazolam or ketamine and a paralytic agent like rocuronium or succinylcholine.
And this circles right back to that pain management point you made earlier.
Exactly. You must differentiate sedation from analgesia. Paralysis means the child can't move, but it does not mean they aren't feeling pain. A chemically paralyzed child can still be in severe pain or distress.
So analgesia needs to be explicitly addressed even after paralysis.
Absolutely, it's a critical aspect of humane care.
Okay, the tube is in. Now what? How do you troubleshoot if things go south?
Continuous monitoring is vital capnography, pulse ox, auscultation. If the intubated child suddenly deteriorates, we immediately run through the DOPE mnemonic for troubleshooting.
DOPE. Okay, break that down.
D is for displacement, did the tube move out of the trachea? O is for obstruction, is it plugged with secretions? P is for pneumothorax, did the procedure or ventilation cause a collapsed lung? And E is for equipment failure, is the bag, the ventilator, the oxygen source working?
DOPE, displacement, obstruction, pneumothorax, equipment.
Got it.
And always confirm placement.
Always. End-tidal CO2 detector turning yellow is the gold standard for confirming tracheal placement, along with bilateral breath sounds and chest rise.
Okay, let's pivot now to some specific pediatric emergencies, starting where, as you said, most pediatric arrests begin. Respiratory arrest.
Right. We know the risk factors: small airways, underdeveloped immune systems, risk of SIDs in infants. What are the clinical signs you're looking for that scream trouble?
Signs of increased work of breathing, right?
Exactly. Nasal flaring, retractions where the skin pulls in between the ribs or above the clavicles, and head bobbing, especially in infants, as they use neck muscles to try and breathe.
And cyanosis.
Central cyanosis, that blue tinge around the mouth or on the trunk, is a very late, ominous sign. Arrest is likely imminent. If you see that, don't wait for it.
Anything specific to infants we should know about breathing patterns?
Yes, you should recognize periodic breathing. Very young infants might take short pauses, like 5–10 seconds, between breaths. As long as they stay pink, heart rate is stable, this can be normal. It's often misinterpreted as apnea, but true apnea is longer pauses or associated with color change or bradycardia.
Good distinction. Okay, next major category, shock. The failure to deliver adequate oxygen to the tissues.
And the critical physiological difference here, remember, is that a child's cardiac output primarily relies on their heart rate, not their stroke volume, like an adult. Their hearts are less compliant.
So if they need to increase output, they mostly just beat faster.
Exactly. That's why tachycardia is often the earliest and most reliable sign of compensatory shock in children.
How do we classify shock?
We classify by type. Hypovolemic, meaning low volume, is the most common in kids from dehydration or hemorrhage, but there's also septic, cardiogenic, distributive, and we classify by severity.
Compensated versus decompensated.
Right. Compensated shock means they have signs of poor perfusion, maybe cool extremities, delayed cap refill, weak peripheral pulses, but their compensatory mechanisms, like that tachycardia, are still holding their blood pressure up.
But they're working hard to do it.
Very hard. And once they cross that line into decompensated shock, the blood pressure finally drops. That means the body's mechanisms are failing, and the situation is rapidly becoming dire. Cardiovascular collapse is near.
So after giving those aggressive fluid boluses, what tells you things are improving?
Indicators of fluid improvement are vital to watch for. Stronger peripheral pulses, improved mental status. Maybe they become more alert or less irritable, warming skin, faster cap refill, and crucially, measurable urine output. The goal is usually 1 to 2 millil GHR.
And if you're not seeing that improvement after fluids?
Then you need to think beyond just fluids. You need to escalate rapidly to vasoactive medications, pressors like epinephrine or dopamine, or potentially blood products if hemorrhage is suspected.
Okay. Finally, cardiac arrest and arrhythmias. You said primary cardiac arrest is rare. So what rhythms do we see when the heart stops secondarily?
The most common pulseless rhythms in children are actually asystole flatline and PEA, that pulseless electrical activity we discussed.
And how do we treat those?
That-
Not shockable, right?
Correct. They are non-shockable rhythms.
Yeah.
Management is high-quality CPR and epinephrine given every 3-5 minutes. And while doing that, you're aggressively searching for and treating the underlying reversible causes, the H's and T's.
H's and T's, like hypoxia, hypovolemia, hydrogen ion acidosis, hyperkalemia, hypothermia, and tension pneumothorax, tamponade, toxins, thrombosis.
Exactly. You have to fix the underlying problem that caused the heart to stop. What about rhythms before full arrest? Bradycardia.
Bradycardia in a child, especially if the heart rate drops below 60 beats per minute with signs of poor perfusion, that's almost always secondary to profound hypoxia. It's an ominous sign.
So the treatment isn't primarily drugs for the heart rate.
Not initially. The primary treatment is to fix the underlying cause. You start effective ventilation and oxygenation immediately. Give oxygen, open the airway, support breathing. Often, the heart rate will come right back up once they're oxygenated. If it doesn't, despite good oxygenation and ventilation, then you consider epinephrine or atropine.
Makes sense. Treat the hypoxia first. What about fast rhythms, tachyarrhythmias? They can be a diagnostic puzzle. You need to distinguish sinus tachycardia, which is fast, yes, but usually responds to something like fever, pain, or dehydration. It typically has beat-to-beat variability in rate and normal P waves. Versus SVT, supraventricular tachycardia. This is often very fast, rates frequently above 180 in children or 220 in infants. The key features are usually an abrupt onset and termination, and the rhythm is typically rigid, machine-like, with little to no beat-to-beat variability. P waves are often hidden or abnormal.
And SVT needs specific treatment.
It does. If the child is stable, you might try vagal maneuvers first, like ice to the face in infants. If that fails, the go-to drug is adenosine, given rapid IV push. If the child is unstable with SVT or adenosine fails, then synchronized cardioversion is needed.
Okay, that clarifies the common rhythms. Let's quickly touch on a few specific traumatic scenarios. Near drowning, what are the immediate priorities?
Immediate ABCs, as always. But crucially, if there's any chance of a diving injury or trauma associated with the submersion, maintain C-spine stabilization throughout resuscitation. Hypothermia is almost universal.
And warming them needs care, right?
Yes, you must raise the core body temperature, but do it slowly and carefully, using active external and sometimes internal warming methods to prevent complications like arrhythmias or worsening acidosis during rewarming.
Okay. Poisoning. Key pearl.
If a previously perfectly healthy child suddenly deteriorates without any obvious explanation, always suspect an ingestion. Get that history if you can.
And management.
It's primarily supportive care manage the ABCs. Depending on the substance and timing, measures like activated charcoal or sometimes whole bowel irrigation might be considered after consulting with poison control. But importantly, the American Academy of Pediatrics does not recommend inducing vomiting with syrup of ipecac anymore. It's not effective and can cause harm.
Good to know. Ipecac is out. Finally, trauma. Standard approach.
Standard trauma approach. Primary survey, ABCs to C-spine control. Then the secondary survey, D for disability, E for exposure, get their clothes off to look for injuries.
Any critical neuro findings in the secondary survey?
Yes. If you notice unequal pupils or a fixed and dilated pupil, that is an immediate neurosurgical emergency. It strongly suggests rising intracranial pressure, possibly from a bleed or swelling.
And a point about managing head injury ventilation.
Yes, a critical practice update. You might instinctively think you should hyperventilate a child with a head injury to lower intracranial pressure, but current practice explicitly avoids routine hyperventilation.
Why is that?
If you hyperventilate, you blow off too much CO2, causing hypocapnia. That hypocapnia forces cerebral vasoconstriction. It clamps down the blood vessels in the brain.
Which sounds bad for an injured brain.
It is. It can starve an already injured brain of needed oxygen and blood flow, causing secondary ischemic injury. So, controlled ventilation targeting normal CO2 levels is key. And remember, trauma patients often need aggressive volume resuscitation, sometimes including blood products, due to blood loss.
Okay, we've covered a massive amount of technical life-saving information. As we conclude this deep dive, let's shift focus slightly from the physical trauma to the emotional one.
Yes, implementing family-centered care is crucial. The nurse's role in supporting the family during what is likely the most terrifying event of their lives is immense.
And this includes?
It often includes clear communication, providing updates, emotional support, and increasingly allowing family presence during resuscitation, if feasible and desired by the family. Evidence suggests it can actually help with coping and grieving.
Communication must be tough in that environment. Any tips?
Keep it simple, direct, and honest. It doesn't have to be complex. During an intervention, offer brief, concrete explanations. For example, I need to put this light on your child's finger to check his oxygen level. It won't hurt him. Things like that.
Small reassurances.
Exactly. And encourage parents to maintain normalcy as much as possible. If appropriate, touching the child, talking to them, maybe reading a familiar book if the situation allows. It's vital for family integration and their coping process.
All right, let's recap the absolute core priorities one last time for everyone listening.
Okay, number 1, prevention of arrest is paramount in pediatrics. Think safety first.
Number 2, when things fail, the ABCs must be rapid and aggressive. Don't hesitate with oxygen, ventilation, or that 20 LO-kg fluid bolus for shock.
And number 3, always remember the fundamental difference. In kids, you are almost always treating underlying hypoxia or shock first, not a primary cardiac problem like in many adults. Treat the cause.
We covered a huge amount of really high-intensity material here, essential stuff.
I did, but let me leave you and everyone listening with one final, maybe provocative thought to carry into your practice. There was a study reviewing pediatric emergency care satisfaction.
Okay.
And it found that when comparing satisfaction scores between the children or adolescents themselves and their parents, both groups consistently ranked the alleviation of the child's pain and feel lowest among all satisfaction items.
Wow. Lowest. So we save their lives, maybe,
Yeah.
but we often fail at minimizing the psychological trauma of the experience itself.
That's what the data suggests.
Exactly. So the challenge for you, the future nurse listening right now, is to really consider, how can you proactively integrate robust pain and fear management protocols before the situation escalates? How can you make true atraumatic care extend beyond just immediate physical survival?
That's a powerful challenge. Essential, life-altering knowledge indeed. Thank you so much for joining us on the deep dive into pediatric emergency care today.
My pleasure.
We'll see you next time.